Periodontal diseases in children present distinct challenges for dental practitioners. This lecture addresses key topics such as the anatomy of the periodontium in children, acute gingival conditions, drug-induced gingival enlargement, mucogingival problems, screening methods for periodontal diseases, periodontal complications of odontic treatment, aggressive periodontal diseases, periodontitis as a manifestation of systemic disease, and Papillon-Lefevre syndrome, PLS. Understanding these aspects is crucial for effective diagnosis, treatment, and management of periodontal issues in pediatric patients, ultimately promoting better oral health outcomes for children. Periodontal diseases overview: infections affecting supporting structures of teeth, marginal and attached gingiva, periodontal ligament, cementum, and alveolar bone. Acute gingival diseases. Herpetic gingivostomatitis and necrotizing gingivitis are ulcerative conditions resulting from specific viral and bacterial infections. Chronic gingivitis. Nonspecific inflammatory lesion of marginal gingiva due to bacterial challenge when dental plaque accumulates in gingival crevice. Development enhanced when routine oral hygiene practices are impaired, reversible with effective plaque control measures. Chronic periodontitis. Results from untreated chronic gingivitis. Characterized by resorption of supporting connective tissue attachment and apical migration of junctional epithelia. Slowly progressing, affects most adults, early stages detected in adolescence. Aggressive periodontal diseases in children. Involves both primary and permanent dentitions, localized or generalized forms. Distinct clinical entities in otherwise healthy children. Non-infectious changes in periodontal tissues. Factitious stomatitis, self-inflicted trauma to oral soft tissues, gingiva usually involved. Drug-induced gingival enlargement, increasing prevalence due to organ transplant procedures and long-term immunosuppressant therapy. Localized enlargement may occur as a complication of orthodontic treatment. Anatomy of the periodontium in children, marginal gingival tissues. Around primary dentition. Highly vascular, fewer connective tissue fibers. Thinner epithelia with lesser keratinization, appearing more red, mild inflammation. Localized hyperemia during eruption can lead to swollen proximal papillae and gingival sulcus depth exceeding 3 mm. During eruption of permanent teeth. Junctional epithelium migrates apically towards the cemento-enamel junction, CEJ. Gingival sulcus depth often exceeds 6 or 7 mm, favoring plaque accumulation. Stability at around 12 years for certain teeth, while others continue to recede slowly until about 16 years. Variation in sulcus depths. Common around posterior teeth in mixed dentition. Difference in sulcus depths due to variation in horizontal position of adjacent CEJs. Attached gingiva. Extends from free gingival margin to mucogingival line minus sulcus depth in absence of inflammation. Necessary for maintaining sulcus depth, resisting functional stresses during mastication, and tensional stress between gingival margin and alveolar mucosa. Width less variable in primary than permanent dentition, possibly explaining scarcity of mucogingival problems in primary dentition. Periodontal ligament and alveolar bone. Ligament space wider in children due to thinner cementum and alveolar cortical plates, less fibrous and more vascular. Alveolar bone has larger marrow spaces, greater vascularity, and fewer trabeculae than adult tissues, potentially enhancing progression of periodontal disease. Radiographic considerations. CEJ alveolar crest distance ranges from 0 to 2 mm for primary canine and molar teeth. Distances up to 4 mm on individual surfaces during eruption or foliation of adjacent permanent or primary teeth. CEJ alveolar crest distance of more than 2 mm should raise suspicion of pathological bone loss in primary dentition, after excluding eruptive and maturation changes. Acute gingival conditions, primary herpetic gingivostomatitis. Primary herpetic gingivostomatitis. Caused by herpes virus hominis. Most common in children aged 2 to 5 years, though older age groups can be affected. Transmission via droplet infection with an incubation period of a week. Clinical symptoms include febrile illness, oral pain, headaches, malaise, dysphagia, and cervical lymphadenopathy. characterized by fluid-filled vesicles on gingiva, tongue, lips, buccal, and palatal mucosa, which rupture to form painful ulcers with inflamed margins. Clinical episode lasts about 14 days with healing, without scarring. Rare but severe complications include aseptic meningitis and encephalitis. Diagnosis and treatment. Diagnosis, typically straightforward based on clinical features, history, and age group. Confirmation possible via smears for ruptured vesicles showing degenerating epithelial cells with intranuclear inclusions. Treatment includes bed rest, soft diet, hydration, and reducing fever with paracetamol suspension. Chlorhexidine may prevent secondary infection of ulcers. Severe cases may require systemic acyclovir, most effective given at onset. Recurrent disease. After primary infection, herpes virus remains dormant in host's epithelial cells. Reactivation or reinfection can occur, presenting as attenuated intraoral form or herpes labialis, cold sore. Cold sores treated with acyclovir cream prevent autoinoculation and spread of lesions. In severe cases of herpes simplex infection, systemic acyclovir can be prescribed as a suspension, 200 mg, swallowed 5 times daily for 5 days. In children under 2 years, the doses have. Acyclovir is active against the herpes virus, but is unable to eradicate it completely. Necrotizing ulcerative gingivitis (NUG) overview. Common acute disease of the gingiva. Prevalent in young adults, 16 to 30 years, in developed countries, while in developing countries, it can affect children as young as 1 or 2 years. Epidemic-like occurrences in certain groups, due to common predisposing factors rather than communicability. Clinical features. Characterized by necrosis and ulceration, starting at interdental papillae and spreading to labial and lingual marginal gingiva. Ulcers are punched out, covered by yellowish-gray pseudomembranous slough, extremely painful. May occur on top of pre-existing gingivitis, with profuse bleeding on probing. Typically poor oral hygiene, distinctive halitosis, common. Surgical recontouring of gingival margin, gingivoplasty, sometimes necessary for tissue architecture improvement and subgingival cleaning. Clinical course and complications. Acute stage transitions to chronic remission after 5 to 7 days, but recurs inevitably if untreated. Chronic cycles lead to loss of gingival contour, rapid bone resorption, and gingival recession. Inadequate or incomplete treatment can exacerbate progressive changes. Etiology. Fusospirochetal complex implicated as causative organisms. Other gram-negative anaerobic organisms also detected. Viral etiology suggested, but specific virus not isolated. Predisposing factors. Poor oral hygiene, pre-existing gingivitis, heavy smoking common factors. Smoking may mediate effects through local irritation or vasoconstrictive action of nicotine. Emotional stress, undernourishment, and debilitation also implicated. Treatment. Patient education on nature of NUG and importance of completing treatment. Smokers advised to reduce smoking. Soft multi-tufted brush recommended for gentle brushing. Short-term use of mouth rinses like chlorhexidine and hydrogen peroxide to reduce plaque formation and cleanse necrotic tissues. Mechanical debridement crucial, possibly with ultrasonic scaler. Severe cases require a 3-day course of metronidazole. In severe cases of NUG, a 3-day course of metronidazole, for children over 10 years of age, 200 mg 3 times daily, alleviates the symptoms, but the patients must be informed that they are required to reattend for further treatment. Chronic gingivitis. Prevalence and association with plaque. Prevalence of chronic gingivitis increases steadily between ages 5 and 12 years, closely associated with plaque, debris, and calculus. National surveys in the UK show an increase in gingivitis prevalence over the years, with improvement from 1973 to 2003. Puberty onset and increase in sex hormones contribute to increased gingivitis in 11-year-olds. Histopathology and microbiology. Inflammatory infiltrate in marginal gingivitis similar to early stages in adults, dominated the sites. Colonization by gram-positive cocci progresses to gram-negative infection with various species like Capnocytophaga, Porphyromonas, and spirochetes. Role of gingival inflammation. Gingivitis is a precursor to chronic periodontitis, but its role in predicting chronic attachment loss may be understood. Severity of gingivitis more reliable predictor of long-term tooth loss than presence of specific pathogens. Home-based oral healthcare. Treatment and prevention depend on achieving and maintaining plaque control compatible with health. Toothbrushing is principal method, recommended twice daily with fluoride toothpaste, starting from eruption of first primary tooth. Supervised brushing recommended until at least 7 years old or until manual dexterity develops sufficiently. Powered toothbrushes offer alternative, beneficial for specific groups like those with orthodontic appliances or special needs, but efficacy compared to manual brush conclusive. Dental flossing less widespread, but supervised flossing beneficial for high caries risk children, introduced when manual dexterity develops sufficiently. Drug-induced gingival enlargement is a well-known adverse effect associated with certain medications. Here's an overview of the causes, clinical features, and management of this condition. Commonly implicated drugs. Phenytoin, an anticonvulsant used to manage epilepsy. Phenytoin induces gingival enlargement about 50% of dentate subjects taking the drug, with teenagers and institutionalized individuals being most susceptible. Cyclosporin, an immunosuppressant used in organ transplant patients. Approximately 30% of patients develop gingival enlargement, with children showing higher susceptibility than adults. Nifedipine, a calcium channel blocker used to control cardiovascular issues. Nifedipine causes gingival enlargement in about 10 to 15% of dentate subjects, particularly when used alongside cyclosporin to reduce its nephrotoxic effects. Mechanisms. The exact mechanisms behind drug-induced gingival enlargement vary among medications, but may involve effects on fibroblast proliferation, collagen production, and collagen breakdown. For example, phenytoin may lead to overproduction of collagen, while cyclosporin may affect fibroblast proliferation and collagenase activity. Clinical features. Gingival enlargement typically manifests after 3 to 4 months of drug administration. Interdental papillae become nodular before diffusely enlarging and encroaching upon labial tissues, particularly affecting the anterior part of the mouth. Enlarged gingiva appears pink, firm, bold, compromising oral functions like eating and speaking, especially when severe. Management. Oral hygiene instruction, scaling, and polishing are essential components of management. Severe cases may require surgical excision, gingivectomy, followed by recontouring, gingivoplasty, to restore proper gingival architecture. A follow-up program is crucial to maintain plaque control and detect recurrence, as causative drugs are often taken long-term. In refractory cases of phenytoin-induced enlargement, modifying or changing anticonvulsant therapy may be considered under the guidance of the patient's physician. Understand causes, clinical features, and appropriate management strategies for drug-induced gingival enlargement is essential for effective patient care and prevention of associated complications. Traumatic gingivitis, understanding and management. Traumatic gingivitis, specifically gingivitis artefacta and factitious gingivitis, presents unique challenges in diagnosis and management. Here's an overview. Types of traumatic gingivitis. Gingivitis artefacta, minor. This form typically results from behaviors like rubbing or picking the gingiva with fingernails or abrasive foods. It may be triggered by an existing locus of irritation, such as food packing or inflamed papilla. Lesions resolve once the habit is corrected and the source of irritation is removed. Gingivitis artefacta, major in this more severe form, injuries are widespread and can involve deeper periodontal tissues. Patients may exhibit injuries in other oral areas and even extraoral injuries like factitious dermatitis on the scalp, limbs, or face. Patients often show indifference towards these lesions and may not recall their onset or management. Oral care. Dentists should focus on dressing and protecting oral wounds caused by traumatic gingivitis. However, treatment beyond this scope does not typically fall under the dentist's purview. Psychological evaluation. Given the complex and often obscure psychological reasons behind behaviors, referral to a psychologist or psychiatrist is essential. While older children or their parents may be reluctant, psychological consultation is necessary to prevent further self-inflicted harm. Prevention and long-term care. Addressing the underlying psychological issues is crucial for preventing traumatic gingivitis and associated injuries. Long-term management may involve psychological counseling or therapy to address underlying emotional or behavioral issues contributing to the self-injurious behavior. Understanding the psychological aspects and seeking appropriate professional help are essential in managing traumatic gingivitis effectively and preventing potential harm to the patient. Mucogingival problems in children. In children, mucogingival issues, particularly gingival recession, pose unique challenges due to the dynamic nature of the developing dentition. Here are some key points to consider. Narrow keratinized gingiva, KG. Children often present with narrow zones of keratinized gingiva, especially during the mixed dentition phase. The width of KG varies as permanent teeth erupt, sometimes appearing to emerge through alveolar mucosa initially. However, an obvious width of KG is eventually established. Factors contributing to gingival recession/causes of gingival recession. Labial displacement of permanent incisors is a common cause of gingival recession in children, with about 80% of affected teeth being displaced labially. Aggravating factors such as gingivitis or excessive and incorrect toothbrushing further increase the risk of recession. Orthodontic therapy, particularly labial tipping of incisors, can also lead to gingival recession as roots move labially through the supporting alveolar bone. Conservative treatment approach. When gingival recession occurs in children, a conservative treatment approach is recommended. Recording the maximum distance from the gingival margin to the cemento-enamel junction, CJ, essential for monitoring. Modification of overenthusiastic toothbrushing practices and provision of scaling and polishing may be necessary. Close monitoring of recession is crucial until the permanent dentition is complete. Longitudinal studies suggest that as supporting tissues mature, gingival attachment tends to spontaneously creep coronally, partially covering denuded root surfaces. This natural process is preferred over corrective surgical intervention to increase KG width. Understanding the dynamics of mucogingival problems in children and adopting a conservative treatment approach can help mitigate the impact of gingival recession and promote optimal periodontal health as the dentition matures. Chronic periodontitis in children. Prevalence variation. Prevalence varies due to different diagnostic methods and cutoff levels for determining disease presence. Radiographic and clinical measurements are used, with different studies using varying cutoff values, 1, 2, or 3 mm. Age and attachment loss. Loss of attachment is uncommon under the age of 9 years, but microscopic examination shows minimal attachment loss. Adolescent diagnosis. Cutoff levels for diagnosis in adolescents vary. Larger cutoff values result in lower disease prevalence. In one UK study, 51.5% of 14 to 15-year-olds were diagnosed with periodontal disease using a 3 mm CEJ, AC distance, likely overestimating prevalence. Prevalence estimates. Most studies put disease prevalence in adolescents at 1 to 11% using a millimeters cutoff value. Observations. Loss of attachment at interproximal sites correlates with subgingival calculus presence. Positive correlation between periodontal destruction and DMF teeth or surfaces suggests independent progression of periodontal disease and caries. Loss of attachment buccal or palatal surfaces is often associated with trauma from incorrect brushing technique rather than inflammation. Screening for periodontal diseases in children. In the 1980s, the British Society of Periodontology introduced the Basic Periodontal Examination, BPE, as a screening system for periodontal diseases in general dental practice. Here's how it works. Probe used: a 0.5 meters ball-ended Hu 621 probe with a black band between 3.5 and 5.5 millimeters from the tip is used for probing gingival and periodontal pockets. Code range 0 to 4. 0. Healthy gingiva with no pockets or bleeding after probing. 1. Bleeding after probe but no calculus present, entire black band remains visible. 2. Calculus or other plaque retentive factors present, bleeding may occur, entire black band visible. 3. Shallow pocket with band partly visible above gingival margin. 4. Deep pocket where band disappears subgingivally. Asterisk addition denotes a sextant with tooth furcation involvement or where pocket depth and gingival recession are greater than or equal to 7 mm. Treatment guidelines: treatment needs are determined based on scores. Lower scores may indicate plaque control measures. Higher scores may require scaling, root surface augmentation, or referral to a specialist periodontist. Adaptations for children under 18. Index teeth: 6 index teeth, 16, 11, 26, 36, 31, and 46, are used. Age-specific codes. Codes 0, 1, and 2 used for children aged 7 to 11 due to prevalent false pockets. Full code range used for children and adolescents aged 12 to 18. Radiograph consideration: codes 3 or May 4 indicate the need for intraoral radiographs to check for bone loss. Orthodontic patients: the system is used for patients under 18, especially those about to undergo orthodontic treatment. Risk factors for periodontal conditions and diseases can be classified as local or general. Here's an overview. Local risk factors. Malocclusions: misaligned or rotated teeth can hinder effective cleaning, leading to plaque retention. Traumatic occlusion may damage the periodontal port. Traumatic dental injury: injuries like luxation, intrusion, or avulsion can damage the periodontal ligament and alveolar bone, increasing tooth mobility. Plaque retentive factors: various factors, including dental anomalies, like supernumerary teeth, odontomes, talon cusps, etc., and iatrogenic factors, like orthodontic appliances, poorly fitting crowns, etc., can compromise periodontal health by promoting plaque retention. General risk factors. Genetic conditions: certain inherited conditions, such as Papillon-Lefevre syndrome, may predispose individuals to periodontitis. Metabolic, hematological, and environmental factors: conditions like diabetes mellitus and smoking are significant general risk factors. Diabetes mellitus, type 1 diabetes, especially when poorly controlled, can increase the risk of periodontal disease. It affects immune function, inflammatory networks, and connective tissue matrix deposition. Smoking. Smoking is a significant environmental risk factor for periodontal disease. It increases the prevalence of periodontal pathogens, reduces salivary IgA levels, impairs phagocytosis, and alters T-cell populations. Overall, understanding these risk factors is crucial for assessing, diagnosing, treating, and maintaining periodontal health in children and adolescents. It's important to note that while these factors increase the likelihood of developing periodontal disease, their presence does not guarantee disease development, and vice versa. Periodontal complications of orthodontic treatment. Gingivitis. Cause: accumulation of plaque due to reduced access for interproximal toothbrushing with fixed appliances. Impact: encroachment of metal bands exacerbates gingival health issues compared to bonded appliances. Supragingival plaque: tipping movements can shift supragingival plaque into subgingival locations, worsening gingival health. Gingival enlargement. Location: anterior palatal gingiva and mucosa may enlarge due to tissue compression during appliance use. Resolution: changes may resolve post-treatment, but intervention may be necessary to address persistent enlargement. Attachment and bone loss. Coronal attachment loss, mean annual rate ranges from 0.05 to 0.30 mm, comparable to untreated populations. Root resorption, excessive forces during orthodontic can lead to apical root resorption, considered as attachment loss. Gingival recession. Occurrence, labial movement of incisors may lead to unpredictable gingival recession, especially with thin alveolar bone or bone defects. Trauma. Cause, direct irritation by components of fixed appliance during bonding, banding, and wire/elastics placement. Consequences, chronic irritation may lead to acute inflammatory reactions, gingival enlargement, or fibrous epulis formation. Aggressive periodontal diseases. Rare but rapidly progressing infections affecting primary and permanent dentitions. Associated with specific microbial challenge and inherent defect in host's immunological response. Can lead to premature tooth loss at an early age. Diagnosis and monitoring. Prompt diagnosis essential for successful treatment. Regular monitoring of periodontal status necessary to ensure treated disease remains quiescent. Historical perspective. Previously known as early-onset diseases, prepubertal and juvenile periodontitis. Classification system in 1999 combined these into one entity, aggressive periodontitis. Recognized to affect both primary and permanent dentitions in localized and generalized forms. Primary dentition. Presentation. Gingiva appear fiery red, swollen, and hemorrhagic in generalized form. Hyperplastic tissues with granular or nodular proliferations precede gingival clefting and extensive recession. Gross plaque deposits due to difficulty in maintaining oral hygiene. Progression. Extremely rapid, with primary tooth loss as early as 3 to 4 years of age. Bone loss may be restricted to one arch, susceptibility to recurrent general infections like otitis media and upper respiratory tract infections. Localized form. Progresses more slowly, with bone loss affecting only incisors and molars. Minimal soft tissue changes with low plaque level. Microbial factors. Predominant microorganisms. Aggregatibacter, previously Actinobacillus, Actinomycetum comitans. Porphyromonas gingivalis. Fusobacterium nucleatum. Eikenella corrodens. Infective components suggested, along with effects in host response. Immunological defects. Profound abnormalities in chemotaxis and phagocytosis of polymorphonuclear neutrophils and monocytes. Heritable risk factors defining disease entity, phenotypically. Treatment. Oral hygiene instruction, scaling, and root surface instrumentation. Bacterial culturing of pocket flora to identify specific periodontopathogens. Systemic antibiotics like metronidazole or amoxicillin for persistent pathogens after debridement. Generalized disease responds poorly to treatment. Extraction of teeth may improve neutrophil chemotaxis. Severe cases may require extraction of all primary teeth to limit disease. Bacterial culturing of subgingival flora upon eruption of permanent teeth to detect reinfection early. Aggressive periodontitis in permanent dentition. Characteristics. Severe periodontal destruction with onset around puberty. Two main forms. Localized, classically localized around first permanent molars and incisors, not involving more than 2 other teeth. Generalized, involving more than 14 teeth, affecting an arch or entire dentition. Epidemiology. Prevalence. About 0.1% in developed countries. About 5% in underdeveloped nations. Ethnic variation. Prevalence higher in ethnic groups. Example, in the UK, prevalence in Caucasians is 0.02%, Asians 0.2%, and African Caribbeans 0.8%. No difference in prevalence between males and females in some studies. Clinical and radiographic features. Onset, between 11 and 15 years of age. Clinical features, pocket formation, loss of attachment around permanent incisors and first molars. Radiographic pattern, bilateral angular bone defects around molars, sometimes around incisors, bone loss detectable on bite radiographs. Bacteriology and pathogenesis. Subgingival microflora includes Eikenella corrodens, Capnocytophaga species, Prevotella intermedia, Aggregatibacter actinomycetum comitans. Actinomycetum comitans is most frequently implicated, found in over 90% of patients. Raised IgG titers to actinomycetum comitans, which falls after successful treatment. Actinomycetum comitans pathogenicity due to ability to invade connective tissues, production of virulence factors inducing bone resorption, colinase, epitheliotoxin, fibroblast inhibiting factor, and leukotoxin. Bacteriology and pathogenesis continued, About 70% of patients have defects in neutrophil chemotaxis and phagocytosis. Chemotactic defect linked to reduced amounts of cell surface glycoproteins, transmitted dominantly. 50% of siblings of patients with aggressive periodontitis and chemotactic defects also demonstrate impaired neutrophil function. Treatment. Combined regimen. Regular scaling and root surface instrumentation. 2-week course of systemic tetracycline therapy. Alternatively, combination of metronidazole and amoxicillin. Surgery for better access to root surface instrumentation and excision of infected connective tissues, with antimicrobial regimen. Genetic factors and aggressive diseases. Increased prevalence in certain ethnic groups and families suggests genetic influence. Functionally defective neutrophils implicated in genesis. Mode of transmission not fully determined. X-linked dominant mode of inheritance with reduced penetrance suggested. Large family studies suggest autosomal recessive pattern of inheritance. Genetic markers. Major histocompatibility complex, MHC, implicated in susceptibility to diseases. Associations between HLA serotypes and aggressive periodontitis, though not as strong as with other diseases like diabetes mellitus and rheumatoid arthritis. Metronidazole and amoxicillin. A combination of metronidazole and amoxicillin, along with subgingival scaling, has been demonstrated to be effective in treating certain types of periodontal diseases, including aggressive periodontitis. Here's an overview of this treatment approach. Medication. Metronidazole. Dosage, 250 mg, frequency, 3 times daily. Amoxicillin. Dosage, 375 mg, frequency, 3 times daily. Duration. Typically prescribed for a week. Administration. Taken. Mechanism of action. Metronidazole, effective against anaerobic bacteria, commonly found in periodontal pockets. Amoxicillin, broad-spectrum antibiotic targeting various bacteria responsible for periodontal infections. Synergistic effect. Combination therapy with metronidazole and amoxicillin provides a synergistic effect, targeting a wide range of periodontal pathogens, including Aggregatibacter actinomycetum comitans, actinomycetum comitans, and Porphyromonas gingivalis, among others. Adjunctive therapy, administered alongside subgingival scaling to quickly remove bacterial plaque and calculus from below the gum line. Effectiveness. Studies have shown that this combination therapy, when used in conjunction with subgingival scaling, can effectively reduce bacterial load, inflammation, and improve clinical parameters of periodontal health. It's important that this treatment approach should be prescribed by a dental professional after thorough evaluation of the patient's periodontal condition, medical history, and potential drug interactions. Additionally, patients should be instructed on proper medication administration and advised on maintaining good oral hygiene practices for optimal treatment outcome. Neutropenias. Definition. Heterogeneous group of blood disorders characterized by a periodic or persistent reduction in circulating polymorphonuclear neutrophils. Causes. Drug-induced neutropenias. Secondary to severe bacterial or viral infections. Autoimmune diseases such as lupus erythematosus. Heritable conditions. Cyclic neutropenia. Benign familial neutropenias. Severe familial neutropenias. Autosomal dominant traits. Often diagnosed in early childhood. Chronic benign anemia of childhood. Diagnosed between 6 and 24 months of age, characterized by frequent and multiple pyogenic infections of the skin and mucous membranes. Periodontal problems. Similar among different types of neutropenias. Patients often present with localized or generalized aggressive periodontitis. Primary dentition may not be involved, signs may appear only with eruption of permanent dentition. Gingiva, inflamed, edematous, may show recession, ulceration, and desquamation. Treatment. Local removal of plaque and calculus. Difficulty in strict plaque control in younger children. Use of antibacterial mouth rinse may be beneficial. Chediac, Higashi syndrome. Rare genetic disorder. Inherited as an autosomal recessive trait. Often fatal. Clinical features. Partial albinism. Photophobia, sensitivity to light. Nystagmus, involuntary eye movements. Recurrent pyogenic infections. Malignant lymphoma. Neutropenia, anemia, thrombocytopenia. Neutrophil defects. Migration, chemotaxis, and phagocytosis impaired. Diminished bactericidal capacity. Periodontal changes. Severe gingival inflammation. Rapid and extensive alveolar bone resorption. Premature exfoliation of teeth. Exact cause of changes not fully understood. Possible factors: plaque-induced, secondary to infection, or related to underlying neutrophil dysfunction. Leukocyte adhesion deficiency syndrome, LAD. Inheritance, autosomal recessive trait. Consanguinity between parents of affected children confirms inheritance pattern. Clinical characteristics. Delayed separation of umbilical cord. Severe recurrent bacterial infection. Impaired wound healing. Formation of pus. Aggressive gingivitis, possibly presenting sign of disorder. Role of leukocytes. Highlight importance of white blood cells in protecting against periodontal disease. Disease progression. Moderate phenotypes may initially appear relatively disease-free but progress rapidly. Majority of patients do not survive beyond 30 years. Progressive periodontal condition difficult to control. Often secondary to other life-threatening infections. This syndrome underscores the critical role of leukocytes and white blood cells in immune defense infections, including periodontal disease. However, the syndrome's severe nature, rapid progression, and high mortality rates pose significant challenges in management and treatment. Papillon-Lefevre syndrome, PLS. Characteristics. Palmar, plantar hyperkeratosis. Premature loss of primary and permanent dentitions. Ectopic calcifications of the falx cerebri. Increased susceptibility to infection in some patients. Inheritance, autosomal recessive trait. Prevalence, approximately 1 to 4 per million of the population. Consanguinity of parents evident in about 1/3 of cases. Dental manifestations. Rapid and progressive periodontal destruction affecting primary dentition. At around 2 years of age, exfoliation of all primary teeth before permanent successors erupt. Patients may be edentulous by mid to late teens. Late onset variant. Some cases exhibit milder palmar, plantar, and periodontal lesions. Manifestations become evident in dentition. Extensive family dental history, along with clinical, laboratory, and radiographic examinations, confirms diagnosis. Ehlers-Danlos syndrome. Inheritance, autosomal dominant trait with 9 variants. Variants exhibit defects in synthesis, secretion, or polymerization of collagen. Most common of the heritable disorders of connective tissues. Clinical characteristics. Of joint mobility. Skin hyperextensibility. Susceptibility to scarring and bruising of skin and oral mucous membranes. Defective type 4 collagen supporting small blood vessel walls predisposes to persistent post-extraction hemorrhage. Oral manifestations. Fragile gingival tissues to bleeding on toothbrushing. Type 8 variant associated with advanced periodontal disease. Periodontitis linked with type 4 variant, while other variants may not be affected. Ultrastructural changes in teeth. Abnormalities of amelodentinal junction. Vascular inclusions in dentine. Fibrous degeneration of pulp. Disorganization of cementum. Treatment considerations. Type 8 patients require thorough preventive periodontal program. Root debridement can cause extensive trauma to fragile soft tissues. Periodontal surgery should be avoided due to risk of hemorrhage, potential complications with suturing soft tissue flaps. Langerhans cell histiocytosis, LCH. Definition. Non-malignant granulomatous childhood disorder. Characterized by uncontrolled proliferation and accumulation of Langerhans cells mixed with eosinophils and multinucleated giant cells. Terminology. Replace term histiocytosis X and related syndromes. Eosinophilic granuloma. Hand, Schuller, Christian disease. Lederer, Siwe disease. Clinical features. Hallmark, lytic bone lesions, single or multiple. Widespread lesions can affect pituitary gland, causing diabetes insipidus, retroorbital region, causing exophthalmos. Disseminated form is aggressive with poor prognosis. Often diagnosed within the first 6 months of life, becoming widespread by about 3 years of age. Periodontal manifestations. Marginal gingivitis. Bleeding gingiva. Abscess formation. Pain. Drifting and mobility of teeth. Radiographic findings, localized or generalized bone loss, characteristic osteolytic lesions, floating teeth with no alveolar bone support. Diagnosis and management. Biopsy confirms diagnosis. Full radiographic screening determines severity. Local lesions confined to bone respond well to curettage and excision. Mortality rate increases in disseminated forms and when overlying soft tissues are involved. Radiotherapy and chemotherapy. Understanding the clinical presentation, radiographic findings, and treatment options is essential for diagnosing and managing Langerhans cell histiocytosis, particularly in cases where periodontal manifestations are the presenting sign. Hypophosphatasia. Rare inborn error of metabolism. Characterized by defective bone mineralization, deficiency of alkaline phosphatase, ALP, activity, and increased excretion of phosphoethanolamine in urine. Pathophysiology. ALP deficiency affects mineralization of hard tissues. Predisposes to bone and cartilage defects. Inheritance. Autosomal recessive trait, although milder forms may have autosomal dominant inheritance pattern. Clinical features. Onset. Juvenile or childhood hypophosphatasia, before 2 years age. Bone defects. Often mild, including bowing of legs, protosis, wide-open fontanelles. Dental features. Resorption of alveolar bone, without marked gingivitis. Premature exfoliation of anterior primary teeth. Hypoplasia or absence of cementum. Presence of small teeth with enlarged pulp chambers due to defective mineralization. Weakened periodontal attachment, predisposing to periodontopathogen infections. Diagnosis. Biochemical confirmation. Low activity of serum ALP. Raised level of phosphoethanolamine in 24-hour urine sample. Down syndrome, trisomy 21. Periodontal disease characteristics. Children with Down syndrome, trisomy 21, typically do not experience aggressive periodontal disease. However, several local and general risk factors associated with the syndrome can contribute to oral health challenges. Local risk factors. Angles class 3 malocclusions with crowding. Lack of an anterior lip seal. Anterior open bites. These factors may increase dental plaque retention. General risk factors. Leukocyte defects play a central role in general riskers for periodontal disease. Defects of polymorphonuclear leukocyte function. Chemotaxis. Killing. Phagocytosis. Reduced T-cell activity. Understanding the unique local and general risk factors associated with Down syndrome can aid in preventive dental care and management strategies for individuals with this chromosomal disorder. Though aggressive periodontal disease may not be prevalent, addressing these risk factors is important for maintaining oral health.